Welcome, ladies and gentlemen, to this new video. I will be presenting another art-essential assisted right colectomy with complete mesocolic excision. I will point out some tips and tricks along the way, so I hope you will enjoy the video. So this is an 84-year-old, rather obese lady who presented to the gastroenterologist with hematochezia. Colonoscopy revealed an adenocarcinoma of the cecum. Imaging revealed no distant metastases. A right colectomy with a CME was recommended by the MDT. We performed an art-essential assisted minimally invasive right colectomy. There were no intraoperative complications and the estimated blood loss was nil. She had an uneventful postoperative course and was discharged on day 6 after surgery. The patient was brought in a 15 degrees Trendelenburg position with a slight tilting to the right. The intraoperative setting can be seen on this slide. The trocar placement as well as the trocar sizes are demonstrated in this image. The patient had an open appendectomy before, so some adhesions are encountered in the right lower and middle quadrant. These are dealt with quite easily. The greater omentum is adherent to the ascending colon and has to be mobilized to enable lateral dissection later on during the procedure. Moreover, the omentum has to be turned over towards the upper abdomen to expose the mesocolon once it is time to expose the superior mesenteric vein. Once this task has been achieved, attention is turned to the trites area and medial to lateral dissection is started. Dissection can of course be started right at the level of the trites ligament to try to expose the duodenum, but this can prove to be a difficult task in the obese patient, as in our case here. As a way around this, I would suggest starting medially along the mesocolon of the cecum and then working your way in a cranial manner towards the third part of the duodenum. I also had the luxury of a second surgical assistant standing on the right side of the patient who was helping to provide additional countertraction by lifting up the ascending colon through the 5 mm port brought in through the right middle quadrant. Obviously, articulating instruments provide here excellent improvement of surgical dexterity during this step and later on during the procedure, as I will be demonstrating in a few minutes from now. Dissection is continued in the avascular space between the anterior renal fascia and the mesocolon. As mentioned before, countertraction provided by both assistants is imperative for a safe and impeccable dissection. The first assistant, who is navigating the camera, is also providing countertraction at the level of the mesocolon while making sure that the small bowel does not find its way to the field of dissection. An 8 mm port placed in the middle of the epigastric region is being used for this task. Moreover, notice how the articulating bipolar forceps is also being used to provide countertraction. The articulating feature helps here in keeping the shaft of the instrument from blocking the field of vision. The duodenum is now meticulously dissected away from the mesocolon. The entire third part of the duodenum is mobilized. Dissection is then continued along the second part of the duodenum. Care is taken to avoid injury to the uncinate process, which will be visualized in the next step. The lower border of the uncinate process is now visible. Very careful dissection is now performed to avoid inadvertent injury to the pancreas. A small part of the superior mesenteric vein can now be visualized, which should prompt the surgeon to finish this particular step and proceed to the next one. As already mentioned, this part of the procedure is surely more tiresome in more obese patients. I would still advise to try to start with this step, since it makes the next step much easier, as we shall see in a moment. The operating table is now slightly tilted to the left so as to visualize the mesentery of the ascending colon. The second assistant is prompted to lift up the transverse colon, while the first assistant pushes forward the ileocecal region. This leads to the exposure of the V-shaped junction of the ileocolic with the superior mesenteric vein. Dissection is started at around 3 cm peripheral to the expected junction between the ileocolic vein and the superior mesenteric vein. This task can be more easily performed in less obese patients, but if the aforementioned anatomical landmarks are kept in mind, this should be feasible in all patients. Once the superior mesenteric vein has been visualized, dissection is continued centrally along its surface until the ileocolic vein is identified. The ileocolic vein has now been clearly identified. The planes of dissection can now be joined safely. The dorsal plane of dissection is now accessed. The duodenum can now be visualized and dissection is continued along the course of the superior mesenteric vein. The ileocolic vein is skeletonized, clipped, and transected. In a similar manner, the ileocolic artery, which runs in this case dorsally to the superior mesenteric vein, is skeletonized, clipped, and transected. Dissection is continued along the superior mesenteric vein. The right branch of the middle colic artery is visualized. A small vein collateral is encountered, clipped, and transected. The gastrocolic trunk of Henle is identified. The right branch of the middle colic artery is clipped and transected. Branches of the gastrocolic trunk are dissected and visualized. The superior right colic vein is identified, clipped, and transected. The middle colic vein is identified, clipped, and transected. The transverse colon is then skeletonized at the designated level of transection. An NCLG2 articulating vessel sealing device is utilized for this task. The greater omentum is divided at the designated site of transection of the transverse colon. The first assistant lifts up the greater curvature of the stomach and the lesser sac is accessed by taking down the greater omentum together with the gastroepiploic vessels. This is performed right at the middle of the greater curvature, and transection is continued towards the right side. The gastroepiploic artery is transected on the way, and the hepatic flexor is taken down. It is important to join the planes of dissection at this stage, since the second and third part of the duodenum, as well as the pancreatic head, have already been laid open and visualized from below. Lateral dissection is now completed. Remaining adhesions between the abdominal wall and the ascending colon are dealt with quite easily. As mentioned before, the right gastroepiploic artery, together with any remaining tissue belonging to the right-sided greater omentum, are transected. The typical anatomical view after performing the CME, including the duodenum pancreatic head and the superior mesenteric vein, can now be appreciated. The transverse colon is now completely skeletonized at the designated site of transection in preparation for the upcoming stapling. Any remaining tissue from the greater omentum is also transected at this site. In a similar manner, the terminal ileum is also skeletonized at the designated site of transection. Adequate bowel perfusion is assessed with indocyanine green enhanced fluorescence before transecting the transverse colon with a green load. The terminal ileum is transected with a blue load while taking care to assess for adequate bowel perfusion. Transumbilical retrieval of the specimen is performed by slightly extending the incision in the umbilicus and introducing a size S Alexis retractor into the incision. A small enterotomy is made at the transverse colon and the terminal ileum in preparation for performing a partially stapled isoperistaltic intracorporeal anastomosis with a blue load. The common enterotomy is closed with a 3-0 V-lock suture. Some surgeons would like to put in stay sutures to hold the bowels together before stapling so to have better control. We used to do this before, but with increasing experience we have come to realize that with correct positioning of the patient, stay sutures may be dispensable. I always use 2 V-lock sutures for enterotomy closure. Suturing is performed from both sides and the sutures are then tied together midway. The first knot of each suture is placed intraluminally. Once the sutures are tied together in the middle, I perform a second row, staying only at the seromuscular level. This is not absolutely necessary, but we have had an excellent experience doing it this way. Moreover, this seromuscular suture is not time-consuming and is quite easy to do. A bilateral transversus abdominis plane block with ropivacaine is introduced at the end of the procedure in a typical manner. If you would like to see more of these videos, make sure to subscribe to my channel. Thanks for watching, and until next time.